So in this video, we're going to be discussing the metabolism of fructose and galactose in the human body. So we have three main monosaccharides that our body uses. The first is glucose, the second is fructose, and the third is galactose. So we talked about glucose and how it's metabolized in our body via the process of glycolysis. So in this video, we're going to be discussing the metabolism of fructose in our body and the metabolism of galactose in our body. So before we start discussing the metabolism of fructose and galactose in our body, we're going to first discuss the absorption of monosaccharides in the GIT. So on this side is going to represent the GIT lumen, which all the food is being digested, and on this side is going to represent the blood. So we want to absorb monosaccharides from the lumen and all the way into the blood. So glucose and galactose are absorbed by something called the sodium glucose transport protein 1. Fructose is going to be absorbed by something called a GLUT5. So this is going to be a special transporter for fructose. So the first thing that you have to notice is that here we have a sodium-potassium ATPase pump. This is going to pump sodium out of the cell. This is going to lead to a low concentration of sodium inside the cell. So when sodium is absorbed by the sodium glucose transporter, it's going to pull along glucose and galactose with it. So this is how glucose and galactose gets absorbed in the GIT. Fructose is directly going to be absorbed by facilitated diffusion by a GLUT5 transporter. So fructose is going to move from high concentration inside the GIT lumen into the enterocytes. The last step is going to be the transportation of glucose, galactose, and fructose from the enterocyte into the portal circulation or into the blood. And this is going to be achieved by a GLUT2 transporter. Okay, so now we're going to discuss in detail the metabolism of fructose. So fructose is a monosaccharide, and it's mainly found in the disaccharide sucrose. So sucrose is the normal table sugar that we ingest. So sucrose is a disaccharide that's composed of a molecule of fructose attached to a molecule of glucose. And sucrose is degraded by the enzyme sucrase enzyme that is found in the small intestines. So fructose, when it enters our body, it's going to be metabolized, and it's eventually going to pour into the glycolysis pathway. So right here, this is the overview of the glycolysis pathway. So when fructose enters our body and it reaches the liver, it's going to be metabolized into either glyceraldehyde 3-phosphate or dihydroxyacetone phosphate. And it's at this point where fructose is going to enter the glycolysis pathway. So when it enters the glycolysis pathway, it could either go up and enter the process of gluconeogenesis to form glucose, or it could go down and finish the process of glycolysis to become pyruvate and form ATP molecules. So, like we said before, fructose is going to be metabolized into either glyceraldehyde 3-phosphate or dihydroxyacetone phosphate, and these are intermediates in the glycolysis pathway. So the first step in the fructose metabolism is going to be the conversion of fructose into fructose 1-phosphate. So we're just going to add a phosphate onto the fructose molecule, and this is going to be catalyzed by the enzyme fructokinase. The second step is going to be the conversion of fructose 1-phosphate into two molecules. The first one is going to be the dihydroacetone phosphate, and the second is going to be the glyceraldehyde. And this is going to be catalyzed by the enzyme aldolase B. Now remember that these two molecules are 3-carbon structures and fructose is a 6-carbon structure. So we're basically going to split it into two 3-carbon structures. The last and the final step is going to be the conversion of glyceraldehyde into glyceraldehyde 3-phosphate, and this is going to be catalyzed by the enzyme triokinase. So it's just going to add a phosphate onto the 3rd carbon of glyceraldehyde. And this is how, and once fructose reaches this stage, it's going to enter the glycolysis pathway. So two additional important notes about fructose metabolism. The first thing is that fructose enters the glycolysis pathway at the level of glyceraldehyde 3-phosphate and dihydroxyacetone phosphate. Now remember that the rate-limiting step in glycolysis is going to be the conversion of fructose 6-phosphate to fructose 1,6-bisphosphate. This means that fructose is going to enter the glycolysis pathway after the rate-limiting step, meaning that the metabolism of fructose is going to be very rapid. The second important thing to know is that a small fraction of fructose molecules can be converted directly into fructose 6-phosphate by the enzyme hexokinase. So now we're going to discuss the disorders that could happen to fructose metabolism in the human body. The first one is called essential fructosuria, and the second is called hereditary fructose intolerance. Okay, so essential fructosuria is a deficiency in the enzyme fructokinase, and this is basically the first enzyme in the fructose metabolism pathway. So in essential fructosuria, fructose is not going to enter the hepatocytes. Now fructose is going to remain inside the blood and it's going to be excreted in the urine. That's why it's called fructosuria. This is a benign condition because the extra fructose is going to be excreted into the urine and it's not going to deposit in any tissue and cause damage. So in hereditary fructose intolerance, this is going to be a deficiency in the enzyme aldolase B, and this is going to be the second enzyme in the metabolism of fructose. So in hereditary fructose intolerance, all the fructose that is located in the blood is going to enter the liver hepatocytes, and it's going to be converted into fructose 1-phosphate by the enzyme fructokinase. Now, once it's converted to fructose 1-phosphate, it's going to be trapped inside of the hepatocyte, so it can't exit and enter the blood, so it can be excreted in the urine. It's going to accumulate inside of the hepatocytes, and it cannot continue to enter the glycolysis pathway due to the deficiency in the aldolase B enzyme. Now this fructose 1-phosphate, once it accumulates, it's going to deplete all the stores of phosphate because all the phosphate in our cells is going to be used to synthesize fructose 1-phosphate. And when you have a shortage in phosphates, this is going to deplete the ability of the cells to synthesize ATP because the synthesis of ATP needs phosphate. Okay, so what is the clinical presentation of hereditary fructose intolerance? Well, it's going to present in a baby who was just weaned off of breast milk. So when the baby's weaned off of breast milk, he's going to start to consume solid foods that contain fructose. Okay, so the increase in the fructose 1-phosphate that accumulates in the liver is going to deplete the ATP in our cells, and this is going to limit the liver's ability to synthesize glucose, so it's going to inhibit gluconeogenesis, and it's also going to inhibit glycogen breakdown. Now, the decrease in the gluconeogenesis is going to cause hypoglycemia, and of course hypoglycemia can present as seizures in infants. The hypoglycemia could also lead to failure to thrive. The accumulation of fructose 1-phosphate in the liver is going to lead to an enlarged liver. There's going to be a decreased ability for glycogen breakdown, and this is going to lead to hepatomegaly and eventual liver damage and liver failure. So patients who have hereditary fructose intolerance, so how do we manage them? Well, of course, they have a problem with fructose metabolism, so they should avoid fructose and they should avoid sucrose because it contains fructose. But another thing that they should avoid is going to be sorbitol. Now, why should they avoid sorbitol ingestion? Now, the reason is that we have something called the polyol pathway, and this is an alternative pathway for the metabolism of glucose, in which glucose can be converted into fructose. So when sorbitol is ingested, sorbitol as well can be converted into fructose, and this is going to increase the fructose 1-phosphate that accumulates in the liver, and this is going to accelerate liver damage. So this is why patients with hereditary fructose intolerance should avoid sorbitol as well. So shifting gears a bit, so now we're going to talk about the metabolism of the last monosaccharide, and that's going to be galactose. So galactose is mainly found in the disaccharide lactose, and lactose is going to be found in milk, and it's going to be degraded in the GIT by the lactase enzyme. So galactose is going to be metabolized into glucose 6-phosphate, and then the glucose 6-phosphate is going to enter the glycolysis pathway. So right here we have the overview of the glycolysis pathway, and as we can see that the metabolism of galactose is going to enter the glycolysis pathway at the level of glucose 6-phosphate. Now note that the glucose 6-phosphate happens before the rate limiting step, which is going to be the conversion of fructose 6-phosphate to fructose 1,6-bisphosphate. So the metabolism of galactose is going to be slower than the metabolism of fructose. Okay, so what are the specific steps in the metabolism of galactose? Well, once galactose enters the hepatocytes, it's going to be converted into galactose 1-phosphate by the enzyme galactokinase. The galactose 1-phosphate is then going to be converted into glucose 1-phosphate by something called the GALT enzyme, which stands for galactose 1-phosphate uridyl transferase. So it's going to consume one molecule of UDP glucose. Now, once we get to the glucose 1-phosphate, this can enter the glycogen synthesis pathway and form glycogen. It could also continue to form glucose 6-phosphate that could either be used in glycolysis or it can be converted into glucose by the process of gluconeogenesis. So what are the disorders that could happen in galactose metabolism? The first one is called classic galactosemia and the second is called galactokinase deficiency. So in classic galactosemia, this is an autosomal recessive disorder in which there's a deficiency in the enzyme GALT. GALT stands for galactose 1-phosphate uridyl transferase, and this is going to be the second enzyme in the galactose metabolism pathway. So the galactose that reaches the liver is going to be converted into galactose 1-phosphate, and it's going to accumulate inside of the liver. That's why it's going to lead to liver damage. Galactose is also going to be shunted towards another pathway because this pathway is broken down. It's going to be shunted towards the polyol pathway. Now in the polyol pathway, galactose is going to be converted into galactitol by the enzyme aldose reductase. Galactitol is going to reach the eye and accumulate in the lens. It's going to cause cataracts. Okay, so what is the clinical presentation and treatment of classic galactosemia? Well, this is going to present in the first few days of life after the baby starts consuming milk. So the liver is going to accumulate galactose and galactitol, and that's going to lead to hepatomegaly, jaundice, and liver failure. So all that galactose that accumulates inside the liver is going to cause liver damage. These babies are also going to have failure to thrive, and if the disease is not treated or managed, it's going to lead to cataracts. So this is usually avoided because there's screening tests that happen, and the screening test is a GALT enzyme activity assay. The treatment is going to be the avoidance of galactose. So babies who have classic galactosemia cannot consume milk. Okay, so the second pathology that could happen in galactose metabolism is called galactokinase deficiency. And this is going to be a deficiency in the enzyme galactokinase, and this is going to be the first enzyme in galactose metabolism pathway. So the galactose that is ingested in the diet is going to accumulate in the blood. It's not going to enter the liver hepatocytes because it can't be converted to galactose 1-phosphate, so it can't be trapped inside the liver. So it's basically just going to remain inside the blood. It's going to be excreted in the urine, and this is what makes this a very benign condition. It's important to know that galactose can still enter the polyol pathway and be converted into galactitol in this disease, and so patients who have galactokinase deficiency can develop cataracts as well.